To start off, let me give you the context of today's webinar. Last June 2023, we had a webinar with several distinguished guests, and we then addressed the issue of the amyloid beta hypothesis. This was in the context of, I believe it was lecanemab that had just been approved by the FDA. Last October, we also had a webinar focusing on a similar topic, that is the issues related to the clinical use of lecanemab. And during that time, we had three distinguished guests, Dr. Rudolph Castellani, who is the Director of Neurology, Neuropathology Core at Northwestern University School of Medicine. Along with Dr. Castellani, we had Dr. Alberto Espi, who is the Professor of Neurology and Director at the University of Cincinnati Academic Health Center. And then we have finally Dr. Carl Harrop, who is Professor of Neurology and an investigator at the Alzheimer's Disease Research Center at the University of Pittsburgh. And I was the moderator and contributed a talk at that time also. So from the previous webinar, we have, to set the stage, we have from Dr. Espi a quote, and it goes like this: lecanemab is neither safe nor effective, and in the end may not justify the means, that is, to lower amyloid, given the toxicity associated with amyloid removal. From Dr. Castellani, quote, clinicians should be vigilant in monitoring for any adverse reactions and be particularly mindful of the interaction with intravenous thrombolytis, that is TPA, because the fibrin that replaces blood vessel walls as a result of drug toxicity is itself a substrate for TPA and thus catastrophic hemorrhage, end quote. And finally, from Dr. Harrop, quote, critical concerns regarding substantial risk profiles and exorbitant costs of these treatments and could threaten the solvency of healthcare systems if adopted widely. And he went on to challenge the clinical significance of the marginal benefits and the absence of a consensus of the therapeutic value of amyloid removal. So this leads into why do we need another webinar on the amyloid hypothesis? Why do we need it? Well, you know, one of the events that prompted this webinar is that donanemab was recently approved several weeks ago by the FDA for use in a mild Alzheimer's disease patient. So we decided to look at the data again and maybe focus it a little bit. So previously, we did not compare the set of studies that concerning drugs that were FDA approved, of which there are now 3, versus all the failed ones. We also decided to focus only on the final iteration of these trials, of all these drugs. That is, we wanted to focus on phase 3 trial data exclusively. So this is a presentation based on our presentation at the AAIC just yesterday. And it's titled Amyloid Hypothesis, 20 Years of Failure in Alzheimer's Research. The authors are Tran and Tran, Zung Tran and Lloyd Tran. So the FDA has so far approved 3 types of drug that are considered anti-amyloid beta monoclonal antibody drugs. And they are aducanumab, lecanemab, and donanemab for the treatment of Alzheimer's disease. Now, historically, I would say 20 years plus, multiple clinical trials have been performed using this class of drugs to test the validity of the amyloid hypothesis. With the current exceptions, no others have been approved for use for Alzheimer's disease patients. So the objective of this presentation is to look at data from past clinical trials of anti-amyloid beta drugs. And we analyze these data to determine safety and efficacy of these trials. And also, I think importantly, to whether the approved drugs, that is aducanumab, lecanemab, and donanemab, these are certainly mouthfuls, differ from the other drugs. So are there differences between these two sets of studies in terms of treatment and placebo based on the frequently reported outcomes for Alzheimer's, that is the CDR-SB and ADAS-Cog? So in terms of methodology, and remember that in science it's very important to describe how you did something, how you got the data, how you got the information, in case there is a lot of doubt, and you are welcome to replicate what I did. And by the way, I will, if you request, I will be glad to send you the database that I constructed and certainly all the references so that you can check up on my analysis and work. So we search for all published evidence for the treatment of anti-amyloid beta monoclonal antibody drugs. These actually included 7 drugs that went to phase 3 levels. And I'm not going to read them all, but they start with aducanumab, bapinuzumab, et cetera, et cetera. There were 15 phase 3 trials for these 7 drugs and 10 publications. They were published in journals like the New England Journal of Medicine, JAMA, et cetera, and neurology journals. Now, keep in mind that many drugs over the last 20, 30 years did not go beyond phase 1 and phase 2 trials. So keeping in mind again that these data come from just phase 3 trials. Now, some of these drugs had multiple phase 3 trials, some up to 4 phase 3 trials. We picked CDR-SB and ADAS-Cog as the outcome measures because these were the most frequently reported outcomes used by these drug trials. With the CDR-SB, keep in mind if you're not familiar, the scale goes from 0 to 18. And for ADAS-Cog, depending on the version, the scale goes from 0 to 70 up to 85, depending, like I said, depending on the version. And also keep in mind that the higher the score, the worse the outcome, the worse behavioral outcome. So getting into a little bit of the statistics so you could understand hopefully a little bit better of how I proceeded. And again, I'll be glad to answer questions by email once we send this out. I'm always enjoy teaching about statistics. So nearly all the trials reported post-treatment differences between drug and placebo. And I'll show you a couple of slides that came from the actual publications. So the difference in score between the treatment relative to placebo at the end of the trial was our unit of analysis, so to speak. On scales where a higher score is worse, and both of these scales, that was the case, a negative difference favors the treatment group. That is, when you subtract lower score minus the higher score, you end up with a negative value, right? You learned this in first grade or kindergarten or whatever. So here are 2 examples of what we're talking about. Van Dyke's paper, which is lecanemab, that's the phase 3 trial, that data was submitted to the FDA last year for approval. You can see that this is the difference I'm talking about, all right? At the end point, at month 18. So this final difference is the difference. And then the difference is actually minus 0.45 on a scale of 18. And here the difference is a little bit larger, a CDR-SB score, and this is the most current approved drug, donanemab. And you see here that that difference is negative 0.70. So if you keep that in mind, that's what we're doing in terms of the unit of analysis. Now also look at the pattern of the decline or the worsening of the, as represented by these two figures. So when I looked at that, I thought, you know, to myself, maybe there's a secondary analysis, the second unit of analysis that I need to address. And that is the slope, or which measures the change in score divided by the change in time in terms of weeks or month, right? So that's a slope. Again, that's something you learn maybe in algebra in high school. So nothing, conceptually, nothing very, very difficult. So we calculated the slope of the lines for both drug and placebo groups for all the trials. And so as I was saying, slope equals delta y over delta x, and we get a measure that shows you the decline in value or increase. Now here's the, just a reminder in terms of the slide, this is what we're trying to look at, right? The slope, the decline in the trial arms. All right, so I'm introducing, it's not a new concept, it's been around for a while, but it's called the bootstrap. And it's really a machine learning methodology that resamples single data sets with replacement to create many random samples. So if you're not a statistician or not familiar with this methodology, you're probably thinking to yourself, what the heck is he talking about? All right, I'll have a little slide right after this that kind of demonstrates it a little bit more. But again, it's not very complex. The resampling process allows the construction of sampling distribution. Now, statistical analysis is highly dependent on sampling distribution. So from the sampling distribution that is created by this methodology, you can actually calculate means, medians, standard errors, confidence intervals, et cetera, et cetera. You can test hypotheses and do all sorts of other things, all fun stuff, right? At least fun for a statistician. All right, so here's a simple, almost cartoonish example of what bootstrap samples are all about. So if you look on the very left side, you'll see that there's 1, 2, 3, 4, 5 numbers, right? So let's suppose that those represent a data set that you've collected. We'll keep it simple, n equals 5. So I'll talk a little bit about what it means to sample with replacement, right? So you randomly select one of those little balls. You call them marbles. I mean, as a kid, I loved marbles. So let's say these were all marbles that were numbered. So the first number you select is 4, right? But you replace the 4. So now you tabulate on the sample, the first sample, the number 4, the marble 4. So the second one is you draw the marble 2, number 2, and you know, tabulate it and then put it back. Next one is marble number 5, and replace that. And here's where the concept of replacement shows up, right? So you draw the marble 7, and you tabulate it, you throw it back into the pile. You randomly draw again, and lo and behold, you get the same marble 7 because it was replaced originally. So that, in a nutshell, is what it means to draw randomly numbered marbles with replacement, right? Every marble is eligible to be redrawn again, right? And so you do that a number of times. So, as I mentioned before, for the analysis, we estimate the means. The mean in this case was the slope as well as the difference in the scores at the end of the trial. So these, remember again that these are all published. So all the data comes from published studies available to the public. Nothing secretive here. Using, machine learning, we drew 10,000 samples from the database with replacement. Here's an example, very brief example of the data set and the kind of information that we're collecting. So for each study, You know, for example, the first line is aducanumab. A difference between drug and placebo on the CDR SB scale was a minus 0.26 and so on. And again, this will be part of the presentation that will be sent out, so I'm not going to read all the data points off for you. So just to reiterate, all the clinical trials analyzed were randomized and placebo-controlled. So the average sample size for all these phase 3 trials was between, not the average, but the range was between 252 subjects to 1,072 subjects per arm. The median was 519 participants. The trial length ranged from 76 weeks to 105 weeks, median being 78 weeks. Right, so for the demographics, the average age was 71, the median 71, so that's consistent. The minimum really 70 to 75, so a very tight group of patients. The percent women was around 55, 56% of the subjects were women. So a little tilted towards women, and this is where there's a big discrepancy in terms of the racial makeup or the ethnicity of patients. That the vast majority of participants or patients in these trials are so-called white. That's how they identify themselves, over 80%. With some trials, 97%. Get my train of thought back. All right, so the overall results, the bootstrap means and 95% confidence interval reflecting a difference between drug and placebo were very small. So overall, for the CRSB, it was a difference of 0.25 for all trials. For when you compare or you break it down by approved drugs versus failed drugs, there was a larger difference versus the failed drugs. In other words, 0.33 for the approved drugs and 0.22 for the failed drugs. And keeping in mind that's on a scale of 0 to 18. For the ADS cog, this difference was a little bit larger, as you would expect, because the scale goes from 0 to 70 or 85 depending on the version, and it was 1.01 versus 0.7 for the failed drugs. Right, and here's a table that you could look at when you get this presentation. I'm not going to read all the differences to you. The next is analysis of the slopes. The slopes reflect a trajectory of change in scores. Right? So the slopes showed that all trial arms worsened at almost the same rate. And just keep that in mind, the word worsen. The patients in the treatment or the drug group were only less worse than the placebo arm at the end of the trial. So let me just emphasize that again. Patients in the treatment or drug group were only less worse than the placebo arm at the end of the trial. In other words, nobody maintained baseline and nobody got better. And here's a table. You can look at it once you get the slideshow. All right, so I also showed again what the slopes look like. One of the serious side effects associated with all of these anti-amyloid drugs is what is called amyloid-related imaging abnormalities. Now that's a kind of a strange name for an adverse event, but it's two types. So again, I have a table, broken down by drug, and it's area E and area H, and it's usually reported as the percent of patients or participants having that condition, right? And I've got the references on the side. Again, you can look it up. For example, I don't mean to pick on aducanumab, but that's just alphabetically, it shows up first. So for example, area E is edema. So that's brain swelling. For the drug condition, there was 26% of participants or patients, placebo 2%. For area H, which is hemorrhaging, the drug condition 16%, placebo 7%. And that's for aducanumab. And all drugs really follow this pattern of area, amyloid-related imaging abnormalities. So, just some conclusions based on the data that we analyzed. That these were all phase 3 trials for aducanumab, et cetera, et cetera, et cetera. For every treatment arm, for the 2 outcomes that we analyzed, that is CDR-SB and ADAS-Cog, the baseline to post-treatment means increase, that is worsen, over the course of each phase 3 trial for every drug. There were no exceptions. The differences in CDR-SB post-treatment scores between treatment and placebo arms were small. Overall, it was 0.25. And for ADAS-Cog, it was 0.79, neither statistically nor clinically significant. The similarity in slopes between treatment and placebo for both CDR-SB and ADAS-Cog suggests that patients in the treatment and placebo arm were declining, that is, getting worse, at about the same rate. So, this analysis does not support the amyloid hypothesis. There's no evidence to suggest that a correlation exists between levels of amyloid beta and measurable cognitive outcomes. A strong statistical correlation is a must-have pathway to causation, and we didn't find that. Given the associated serious events, that is area E and area H, we conclude that there is no justification for the use of the current FDA-approved drugs. We had questions from registered participants, people who registered, prior to today. And so I briefly reviewed them, and there were some that I'll kind of put together. But it has to do with, hey, so we read that these drugs that were approved by the FDA showed statistically significant differences, and that's why they were approved by the FDA, right? P less than 0.05 or 0.01 or 0.001, or just add on the zeros as much as you like. So I would like to address the difference between clinical significance and statistical significance, because that has a bearing not only in amyloid research, but in all medical research, that as practitioners especially, you need to know, or at least understand to some extent, the difference between what is clinically meaningful and statistically significant. You would like to have both, but we'll see which is, I would consider, the more important aspect of the result of any trial. So let's look at clinical significance. All right, so I went back and found some references from experts, right? These are people, neurologists, who worked in this area of research. And the question that I was trying to get information on was for these 2 outcome measures, CDR-SB and ADAS-Cog. That is, what constitutes a meaningful difference between placebo and drug or drug treatment? And so again, I'm not going to read the full table to you. You'll get this in your email. But for example, Lansdal, he was looking at mild Alzheimer's disease, and I think it's a he, maybe it's a she, indicated that for CDR-SB, that is a scale of 18 points, 0 to 18, that the difference should be between 1 to 2.5. And for the ADS cog, it should be between 2 to 5 as a clinically meaningful or significant difference. Well, you contrast that to the FDA-approved drugs, where the average CDR-SB difference was 0.33, right? 0.33 versus a physician who said, hey, I've got to see at least 1 to 2.5 before I consider that clinically meaningful. For the ADS cog, for the FDA-approved drugs as a group, it was 1.01 from our analysis. This reference, Lansdal, said, well, you gotta show me 2 to 5 in terms of the scale. So I guess the bottom line here is that the three current drugs that have been approved, but aducanumab has been withdrawn. So that leaves lecanemab and donanemab. And as you'll see from this table, the standards of clinically meaningful or clinically significant difference is not met. All right, so let's talk about statistical significance and how do you achieve that? And what does it actually mean? So a little statistics 101, maybe 102. This is a graph that shows effect sizes, right? These are standard deviation units. So in the real world, usually it's calculated as the difference between two means. Let's say you've got a baseline mean and a post-treatment mean. So you take those two means and you divide it by the pooled standard deviation, and you get really a unitless value that is in standard deviation units because you divide it by the standard deviation. So, it's usually some fraction, 0.1, 0.2, et cetera, onto 1, 2, et cetera. Now, here's a picture. Let's say the red line, the red bell curve is the placebo, and the blue, the treatment, right? And this represents a difference of 1 standard deviation unit or an effect size of 1.0, right? Now, the important thing that I want to share with you is that look at the overlap. There's a lot of overlap with an effect size of 1. In other words, again, I'm sure you're very familiar with clinical trials in the medical world. So you apply a treatment, not just a drug treatment, any treatment. Let's suppose exercise or a weight loss regime, and so on. There will be people who, in both the placebo and the treatment group, or the control and the intervention group, the placebo obviously refers to a drug, who got better, stayed the same, or got worse in both groups, right? In the control group as well as in the treatment group. Hence this overlap. And this is a good picture that kind of summarizes that relationship. So a couple things that you can control when you're designing a study. And that is, everyone knows alpha, right? This probability of a type 1 error. That is the probability of rejecting a true null hypothesis, which means that you erroneously say when in reality the two means don't differ between treatment and control, but you say, oh, they're different, right? They're statistically different. So what you're trying to do is to avoid what is called a false positive. So you can set that. Usually it's set at 0.05. You can set it lower at 0.01 and so on. So the other parameter that you can set is what is called power. And that's probability of rejecting a false null hypothesis. That is, you want to avoid a type 2 error or false negative. And again, you can set that. Usually it's 80%. 80% power. Sometimes it's as high as 95%. Now this is really dependent on your resources, because that has implications in terms of the required sample size for statistical significance and a given level of power, and how important that trial is. In other words, what are the stakes involved? So high stakes, high power, and low alpha. All right, so I made up this chart to show you the relationship between an effect size and the sample size requirement per group, with alpha set at 0.05. So the blue group, the blue dots reflect a required power of 95%, and the red 80%. And you can see that, you know, the power requirements kind of parallel each other. There's not a whole lot of difference, especially at large effect sizes. So you're familiar now with the effect size of 1. So that's all the way to the right of this chart. And you can see that this is based on the t-statistics, which is a comparison of two independent means. So that's about a 60 per group, 60 participants, 60 subjects, etc. per group. And you can see that it's nonlinear. So as your effect size drops, the sample size requirement gets very large. Right? So you can see that when it's around 0.3 or 0.2, it goes up to, you know, 500, 600 subjects per group or per arm. All right, so how does this all apply with some real data? Well, again, not to pick on just one drug, but I happen to have on hand, obviously, because I reviewed it, the donanemab, published by Sims et al. In 2023. I was trying to do some direct calculations, but I couldn't find enough data for me to actually do the pre to post, divide by standard deviation, et cetera, et cetera. It wasn't in the paper. So I looked at it and said, okay, this looks like an effect size of 0.2, right? And I've been in the clinical trials world for over 30 years, so I can really look at information and kind of wing it and eyeball it. So they said, well, okay, in their methodology, we're going to fix alpha at 0.05. We want 95% power. So for 95% power and alpha is 0.05, you know, I did the calculations, and the minimum requirement is a sample size of 651. So of course, in any clinical trial or in any intervention, you're going to get some dropouts. So we factor in 30% dropout, which increased the required sample size per group to 846. So then I looked at the actual from the paper by Sims, and they randomized 860 to the donanemab group and 879 to the placebo group. And at the end of the trial, they were down to 622 for the donanemab group and 698 for the placebo group, a loss of 28% and 21%. So I was pretty accurate with my guesses, but it's an educated guess. All right, so let's give you something that's a little bit more dramatic, and that would kind of, so you remember it better. Let's take a hypothetical example of sample size requirement. And the point here is that to let you see that how sample size, how effect size really drives the sample size requirement. I mean, it really does, because you can see from the plot I'd given you recently, or a little bit before, that it's a nonlinear relationship, right? So here's your experiment. So you're an aspiring clinical trial director or a scientist, and you have this treatment or drug that you know has to work, right? So you've staked your whole reputation and your livelihood. Right? So if you can show that this treatment or drug works, fame and fortune is going to accrue to you. So unfortunately, or maybe fortunately, unfortunately, your effect size that you've calculated is 0.1. Right? But because you're already a somewhat famous fellow or woman, you have unlimited resource because fame and fortune is really an important aspect for your life. So you want to show that there is a significant difference between the treatment and the control or the placebo, right? Significant difference, you're going to say has to happen at p less than 0.05. All right. So for alpha equals 0.05 and with the power requirement of 95%, right, you approached me, a distinguished statistician. What's my required sample size per group? I said, okay, let me put it into my magic computer. And lo and behold, I say, well, you're going to need 2,600 patients or participants per arm. And if you factor in a 30% attrition, you're going to have to start off with 3,380 participants or patients per group. So for two groups, that's almost 7,000 patients or participants you're going to have to recruit to randomize them. So what's my message about all this? Well, beware of statistical significance. Right? View that with skepticism, because hopefully I've shown you that it doesn't matter how small the difference is, that you can always find statistical significance with a large enough sample size. Okay, so that should be a clear message as you read through your medical journals or any other journal from any field. That's kind of an across-the-board caution. Second, pay more attention to clinically meaningful difference, because that's the application to the real world. Right? Because without clinically meaningful differences between a treatment and a control, or a drug and a placebo, you really have nothing. Right? It's a waste of time.
Thank you so much, Doctor. Dr. Tran, could you please discuss a little further about the idea of less worse?
Yeah, the idea, I think I started using that phrase probably a couple years ago, when I started to review all the information from all the clinical trials from this class of drugs that are called, anti-amyloid drugs, including the ones that have been approved by the FDA, which is lecanemab, donanemab, and aducanumab. So when I started reviewing all the data, I always like to look at the figures that they were published in all these various journals. And what immediately struck me was that, and there's no exception to this, that all the plots that I saw, the lines between the plots that showed the decline in function between or the disease progression between the placebo group and the drug treatment group were almost identical. They were almost on top of each other, except at the end of the trial, there's a small separation, which I spoke to before on these two measures of function for Alzheimer's patient. Right? So I said, okay, well, the differences are marginal, and the disease progression is almost identical between treatment and placebo. So I said, well, the drug people or the drug treatment were less worse. The patients were less worse off than the placebo, but not by much. So I think that's where the term started. I started to use that term.
Very good. Fascinating. What are the implications of the fact that there was no improvement of the disease with serious adverse events occurring? What is kind of the ethical aspect of that? We see a little less worse, but no improvement. Could you comment on that, please?
Sure. You know, I think certainly in a situation like this, there's a level of ethics that is involved. I think that as medical researchers, you have to really focus in, and I spoke to this earlier in my presentation, on whether a difference or whether somebody or a group of patients got less worse, whether that's actually clinically beneficial or meaningful. Because without that, and especially with a drug or a treatment that has potentially very severe side effects, you know, I don't see how anyone could recommend the use of this class of drugs in Alzheimer's patients, because you're talking about a group of patients who are already compromised in terms of their cognitive functions. And then to add another layer of treatment where, you know, not only do you have to go to a clinic to get an infusion of the drug, but you also have to go through screening, whether it's you know, spinal fluid or CT scan and so on. It's a large burden on these folks for almost no reward. Right? So in medical research, we talk about the benefit-risk ratio. And this ratio is way out of whack.
Yes, it seems that way. Again, our documentary series we're producing is Breakthroughs in Neurodegenerative Disease. And what we're discovering is a number of different institutions, initiatives such as the Chan Zuckerberg Initiative and the Allen Institute Initiative have brought together many different scientists from different separate silos. Can you explain why we were so focused on only amyloid and didn't bring anyone else into the conversation per se?
I can give you a few educated guesses, but it's certainly, you know, not my area of expertise. I mean, I've been in the sciences for well over 30 years. And what I find is that, well, number one, scientists are human. They're prone to error. But the idea behind scientific methodology is that it should be self-correcting. So in other words, Chip, if you're a scientist, a colleague, et cetera, and you design an experiment to test an intervention of some kind or a treatment, right? And you get certain results and you publish it, and I look at it and I said, wow, you know, I think Chip is off base. So I look at your methodology and I try to replicate your results, right? And if I can't replicate the results that you presented or claim to have found, then it puts into question not your ability as a scientist, but your hypothesis, right? Did your information support the hypothesis that you proposed? If it didn't, you know, and I didn't find evidence that it would, then maybe a third set of colleagues would also test it. If it's an important topic, you know, people in different labs, research groups will start to hone in on what Chip, the pioneer in this particular area of research, have proposed or hypothesized, right? And if after a few tries we can't replicate your information or your data, then we say, okay, I think we have not shown that Chip's hypothesis is valid. And then we move on to something else. In this area, and again, you know, for me, you'd have to ask other people, but at least for me, you know, it's become institutionalized. So there are a lot of people, institutions involved in this area of research, and it's kind of hard to break out of it. And so it continues, and that's probably all I can say about it.